The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Good afternoon, and welcome to Child Health Specialty Clinic's Transition to Adulthood webinar series. Before we start, I do have a few housekeeping things to take care of. We are offering continuing education credits for nurses and SPSS professionals who attend the live webinar. If you're a nurse looking to receive credits for attending the webinar, please make sure to complete the evaluation survey following the presentation. This will allow me to keep track of who is seeking credits and award you with credit at the end of the Transition to Adulthood webinar series. If you're an SPSS professional looking to receive credit through the Iowa Board of Certification, please email me, Alejandra Scoto, following the webinar so I can make a certificate for you. For those that are in need of a general certificate of participation, please also email me following the webinar and I can provide that information to you. More information about certification will be provided in a follow-up email, and I also ask that all attendees fill out the follow-up survey at the end of the webinar. You'll also be receiving more information involving how to get credits in the follow-up email after the webinar. So now that the housekeeping things are out of the way, I'm pleased to introduce you to our presenter. With us today is Dr. Jody Tate. She's a psychiatrist and clinical professor in the Department of Psychiatry, where she is the Vice Chair of Clinical Services for the Department of Psychiatry and the co-director of the Intellectual Disability/Mental Illness Program. This program includes a specialized interdisciplinary inpatient and outpatient program, education, and advocacy for individuals diagnosed with an intellectual disability and mental illness. We are very happy to have Dr. Tate present today, and please feel free to type in any questions that you may have throughout the presentation in the question box. We will save the questions for the end at a Q&A portion. So without further ado, I'd like to present Dr. Jody Tate.
Hello. I don't know if you guys can see me or not, but I'm waving at the camera. They can see me. Okay.
Yeah.
The world of COVID and Zoom or GoToWebinar or whatever. I usually like my presentations to be really informal with kind of a back and forth, but you know, we adapt and do what we can do given the time. So I'll get going, and then we can hopefully answer questions at the end. So, you know, you see the name of the talk, and I'm going to start by just giving a brief background of kind of where things have gone in the IDD world, and then talk a little bit about our program and intellectual disability in general, and then get into transition to adulthood. So I like to start with talking about this young baby who is a real individual who died at a very young age. But he was born in 1968, and I was born in 1969. So I think it shows how far we've come in, I know I'm getting older now, but in not too long of a time. So Philip was a baby that was born who had Down syndrome, and his dad was a journalist, and they had this baby. And when the baby was born, the pediatrician recommended that they send the baby away to an institution that was a great place, didn't have any oxygen, no medications, no administration, no miracle meds. And the doc, who was an expert in taking care of folks with Down syndrome, had said there's really no reason to feel guilty about that, because putting a Down syndrome baby away is, well, let me say, he said true guilt arises only from an offense against a person, and a Downs is not a person. So if I had been born with Down syndrome, that is what the pediatrician may have said to my parents. So Philip's parents did do that, and he did end up dying early. And so the father had worked with a medical ethicist, and they published a paper in the Atlantic Monthly back in 1968 talking about their experience. So if Philip would have lived, he might have lived in a state school. And this Willowbrook State School was one of the largest institutes for folks with intellectual disability. And the physician there actually was fired for speaking out about the horrific state of the institute. It was overpacked. Patients were essentially just shoved in rooms. and eventually was closed in 1987, secondary to public outcry, partly from Senator Kennedy. So things have improved since that time, but we still have a long way to go. So folks with intellectual disability are still one of the most underserved populations, especially those with intellectual disability and mental illness. There's been a lot of reports on how we can improve care to this population. In 2001, there was a Surgeon General report on certain steps that we should take, many of which really haven't happened. There's a lack of community support and high rates of mortality and morbidity. But one of the main reasons why, well, I shouldn't say maybe, there's multiple reasons why this group of individuals has high rates of mortality and morbidity. But one of the main reasons is because we as healthcare professionals really don't get a lot of education and training on how to work with these folks. When I went to medical school and residency, I had really no education on how to work with individuals with ID, and got out of residency and started seeing folks and found that selfishly, I felt really happy when I worked with this population, and so slowly acquired more and more individuals or patients with ID, and so started doing a lot of reading and found out that I was normal, that the fact that I didn't have any education and I felt like I didn't know what I was doing is how most healthcare professionals feel. And for those of us in medicine, we like to feel comfortable. And so when we don't feel comfortable, we maybe avoid certain patient populations. So that's what happens. And then if we don't understand a population, sometimes we have certain judgments and attitudes that can affect the way we interact. And we have a really complex healthcare system that's hard for me to navigate, and I've been in it for a long time. And so all those things result in increased rates of mortality and morbidity. All right, so I'm trying to figure out the best way to make eye contact with you guys, and I guess I'm just not going to be able to. So, all right, so the next section I'm going to talk about is a description of our intellectual disability mental illness program, which was developed about 6 or so years ago. And so this program is really a combination of the psychiatric community, developmental disability community, and community agencies. We have a pretty fragmented healthcare system, and folks with ID often have complex needs in different arenas. And for many years, I was a solo psychiatrist. I mean, I worked at the university, but working with these individuals, and that there were so many other folks that were involved that it was hard to make contact and be a cohesive team. So this team was developed with the hope that we could provide cohesive care to individuals with intellectual disability and mental illness across the care continuum, so inpatient, outpatient, and community outreach. We also do education and advocacy, and trying to get involved with research as well. So I talked about most of this, and one of our really key components is we never give up. So I'm trying really hard to meet individuals where they're at and do the best we can to get folks to have a best life they can. We have a 4-bed inpatient unit. We see folks in the outpatient clinic at the University of Iowa, and also telehealth. And we've actually worked with the Sioux City Child Health Specialty Clinics to do telehealth in that area. Given COVID, we're not having to utilize that right now, but it's been a great relationship to date. So the link to our website is on there if anyone's interested. Probably could be a little updated, but it's there. This is our interdisciplinary team. So we have psychiatric providers, community outreach folks. We have an internal medicine doc, Pixie Plummer, who's a med peds doc. So she's double boarders in internal medicine and pediatrics and neurodevelopmental medicine. So if anybody out there has patients with really complex medical needs that you really feel like you need some help trying to figure out, Pixie is somebody that is more than happy to work with you, and she's relatively new to our team, so has capacity and she'd be more than happy to see folks. Admission criteria to our overall program is that people that are 18 or older and they have a dual diagnosis, so mental illness and intellectual disability. We really require that the community and the family is an active participant in treatment, and because we really like that team approach. And if anybody has anybody they'd like to refer to Mark Hines, who's our Director of Outreach and Community Services. All right, so that's really brief over our program. And next I'm just going to talk a little bit about intellectual disability and what that means. So probably everyone's aware that, you know, intellectual disability used to be called mental retardation. That changed quite a while ago, and because of the negative connotation that mental retardation had. And I was amazed when my kids were in grade school and I would be on the playground with them and I would hear kids calling each other gay and retard. And I just didn't really think that still happened, but it does. So the terminology was changed. And as along with the terminology changes, they also changed the criteria. So it used to be that for a diagnosis of intellectual disability, you had to have an IQ of 70 or below. Now they've taken out that requirement because sometimes people can have an IQ of maybe 72 or 3 or 5, but they're really unable to function in different domains, whether it's communication or executive functioning or activities of daily living. So they've taken that out to allow some wiggle room for folks that may have a higher IQ, but they still functionally meet the criteria for intellectual disability. How common is intellectual disability? So about 1 to 3% of people have ID, more males than females. And about 30% of folks with ID have a mental illness. There's lots of different numbers in the literature about what that, it might be higher than that, but 30% is a rough number. However, unfortunately, up to 30% of people with ID receive psychotropic medications that treat aggression or self-injury without a psychiatric diagnosis. And even though I'm a psychiatrist and I prescribe meds, I'm really an anti-med psychiatrist. So less is more, which is a whole nother topic about treating challenging behavior and aggression, but beyond the scope of this talk. But I'm not a huge fan of antipsychotics to treat aggression. And speaking of aggression or challenging behavior, there's often a thought that if somebody has intellectual disability, they're automatically going to have challenging behavior, which is not true. It is true that maybe up to about 25 to 50% of people with ID engage in challenging behavior, but most folks with ID do not have challenging behavior. There's a bit of a selection bias, so all the patients I see with ID have challenging behavior because that's an inclusion criteria for the program. And a common reason why folks with ID come to emergency rooms and maybe come to your services as well. But this assumption that challenging behavior equals ID causes a lot of problems, and it's called diagnostic overshadowing. So you assume somebody's hitting somebody or throwing chairs because they have intellectual disability instead of thinking maybe they're constipated. Maybe they're depressed, maybe they have an ear infection. And so I could talk about this topic for about 3 hours, but we will move on. All right, so I don't know if you guys are familiar with the DSM or not, but the DSM is a book that has all the psychiatric diagnoses in it, along with the criteria to make that diagnosis. And there is a DSM, essentially, that's been adapted for folks with ID. So it's called the DMID. So it has all the same diagnoses that the DSM does, but it explains how it might present differently in folks with ID. And it's a really helpful tool. And the first 3 chapters kind of go over why that this book is necessary. Another chapter on what makes an interview different, and how to go about interviewing folks with ID. And then there's a chapter on behavioral syndromes that have intellectual disability associated with them, which is also a good chapter as well. So I highly recommend it if you're interested in this area and have interest in mental health, getting the DMID. So, and they don't pay me anything to say that. So when you talk about ID, oftentimes people think that intellectual disability and autism is the same thing, and it's not. They're totally different things, but there is an overlap. And it's about a 50-50 overlap. It's not exactly true, but that's the best way I remember it. So about 50% of the people with autism have ID, and about 50% of people with ID have autism. And when people have autism and ID, those folks sometimes really do have more challenges than either one alone. So those folks have the strongest predictor of being in a hospital, on psychotropic meds, and engaging in challenging behavior. And most of the folks that I work with have a combination of autism and ID, but it can exist independently, and they're 2 different entities. Okay, now we'll get to the topic of this presentation, transition to adulthood. So I'm an adult psychiatrist, so I only see folks that are 18 or older. And I know that folks that work with kids with ID are frustrated with the system that we have in place. But I can tell you, as an adult provider, I look at that system and I think, wow, there's a lot of resources there. Because when people turn 21, it's just like falling off a cliff. And so, and for all of us, you know, late teens and 20s can be years of, you know, not really knowing what you want out of life, a lot of hormones, a lot of wanting to kind of assert your independence. So you put that in combination with somebody that may have difficulty expressing their feelings, or may have a restriction on their abilities to make their own decisions, and then a lot of chaos can come from that. So during the services, there is a massive cutoff in services. The services that are available are less stimulating, less well organized, less funded. There are studies that have shown that folks that are with ID that are improving in certain skills, once they get to the 20s, it slows down. And it's thought that that's secondary to a lack of stimulating educational activities. There's an increase in challenging behavior and increased psychotropic meds. And psychotropic meds, even though I prescribe them and they're great when needed, but they're overused and they can cause obesity, diabetes, hypercholesterolemia, and so that can have its own problems, which I know you guys are all familiar with. So with this decrease in services, you know, our system hasn't kept up. So even though I talked earlier about there's increased mortality and morbidity, people are living longer that have disabilities. And there is a lack of adult providers. For one, it's hard to find adult psychiatrists, adult primary care providers that are willing or feel comfortable or skilled taking care of these individuals. And as I mentioned earlier, that lack of availability is secondary to lack of training, fear from adult providers that this population will take more time, that, you know, there's high expectations on seeing patients, and so that also adds to the reluctance of adult providers to care for these folks. And so, you know, on a separate note, we're trying, part of our program is in education, and we recently got a grant to improve education to medical students throughout their 4 years and how to care for this population, but we need to do more and more of that. The other challenge is that pediatric healthcare and the adult healthcare systems are very different. And I've not been in the kid healthcare system, so I only know adult. But there is this assumption amongst adult providers that patients really kind of have the capacity to navigate the system and they can work independently. So if you have patients that don't have that skill set and then you have to work with care providers or guardians or parents, that's just another level that many adult providers aren't used to. There's poor communications between child and adult services. Even in psychiatry, our child psychiatry division and our adult division, we don't communicate as much as we should. And there's a lack of preparation of pediatric providers to transition to adulthood. And unfortunately, what this results in is many folks don't receive adult services until there's some emergency situation. And that's unfortunate. All right, so how can you help? So, you know, I think everyone knows we have a broken healthcare system. So we have to do our best within this broken system. But I do think I kind of simplified it to 5 things that I think will help with that transition. I think it's going to be rocky even in the best of times because of our challenges, but I do think there's some really concrete things that folks can do in the kid world to help with that transition. And I'll talk about each one of these independently, but one is talk about guardianship, talk about sex, talk about someone, think about and talk about what they're going to do with their life. Where are they going to live? Are they going to work? What are they going to do? Who are they going to love? Support family and caregivers and transition to an adult provider. So this guardianship thing is so important. And I'm assuming most folks know what this is, but just so we're all on the same page, once somebody is 18 or older, if they don't have a guardian, then they're in charge of their own decisions. So I am shocked by how many folks that I start seeing that are 19, 20, 21, 22, that their parents aren't guardian, or they don't have a guardian. They have intellectual disability, and their parents just haven't quite gotten around to it yet. And it creates a lot of challenges. I could tell you case after case, and it takes so long to get a guardianship. So that is so important. Even if there's just one thing that you do, I would say this is the one. And if somebody doesn't have family that are going to that want to or have the capacity to, then there are other opportunities out there, and those even take longer. So thinking about this early and talking to family about it is so important. And I've had parents that are extremely high functioning, wealthy, lots of tools, lots of people that they can ask for help, and they just haven't done it. So it's not like this is something that only affects those that have more barriers. It affects the whole wide array. So please talk to them about guardianship. The next is sexuality. This is a 20s, you're in your 20s. That's a big year for sexuality and teenage years. And oftentimes this topic is totally ignored for folks to have intellectual disability, and there isn't good education. And if it is talked about, it's usually in a negative way, and something that needs to be treated. And this is really tough because folks with ID have high rates of sexual abuse. And so you need to make sure that we're protecting individuals because they're a vulnerable population, but also making sure that you know, they feel comfortable talking about masturbation, or they know how to masturbate, they know where's appropriate place to masturbate, talking about relationships, because it's had so many young men come who haven't had, they don't know how to masturbate, they don't know where the appropriate place is to do it, and it results in inappropriate sexual behavior that people want to treat. And really what they need is education and training on what's appropriate and what's not appropriate. There's a lot of myths too. The thought that people with ID are asexual, not true at all. And sometimes it's really hard for parents because, I mean, I'm a parent of a teenage kid, and I don't really want to talk about sex or think about it, but we need to, and it can be more challenging when folks have intellectual disability. There's also this thought that if they have intellectual disability, they can't be gay. And that causes some challenges too. So, or talking about it will encourage them to do it. So that's an area that doesn't have an easy, quick solution to, but I think being aware of that and talking about it is very important. There is this healthy relationships training program that pre-COVID we were running here. We haven't gotten it back up and going now because of the restrictions with COVID, but we hope to in the future. But it's a 12-week course that's both education, kind of didactic stuff, and also kind of out in the community stuff. So it's not just sex education, it's relationship building, appropriate boundaries, who to talk to, who to not talk to. So if anybody's interested, there's the link there, and anybody can take the course and become certified and teach it in your area. All right, so also transitioning to adulthood, there's lots of decisions to be made. Where are they going to live? Are they going to go to school? Where are they going to work? Where are they going to play? How to develop relationships? So that part of us that is so important is what are we going to do with our lives? So up to age 21, school really provides so many resources. And helps with a lot of things. But as I said before, when you turn 21, all those things go away. And honestly, for many of my patients who engage in challenging behaviors, they kind of get pushed out of these services earlier. The schools don't really want them around anymore, and so they get pushed out. Now that's my view, but that's what it feels like and seems like from my perspective. So it's really important that folks have funding. So there's this thing called the ID waiver, which is Medicaid funding to support folks to maintain community living. And there's a variety of agencies that have group homes or hourly services, and I've listed some on here. There's some families that don't want their kids to go to a group home, or but they want help, or they want direct care staff to kind of help care for their child. And so there's this option called consumer choice option, where you can, the parents or the guardians can become the person that gets the funding, and then they pay the direct care providers to come into their house to help provide care. So talking to families to make sure that they get the funding they need to transition to that next level of care is very, very important, because it used to be pretty easy to get an ID waiver. Now it can take years to get it. So very important. And if you don't have this, you can't access the services. So where to live? There's a variety of places that individuals with ID live, just like other folks. So some live with their parents or guardians. There are host homes, so a family will choose to have an individual live with them, and the family does get payment through the ID waiver, but they are a host home, and I have a handful of folks that live in host homes. There's some supported community living, which is generally a group home setting, or there's intermittent care facilities, or ICFs. And this picture is a home where one of my patients live, and these homes are this one is bigger, but they just look like any other home in a community where individuals live, and they have roommates and they have staff. All right, how about schools? So there's two options in Iowa that I'm aware of. There's probably more than that, but one is the VITAL program, which is at Kirkwood Community College, and this is for individuals 21 or younger, so it has to be part of their IEP, but it has some individualized training. And then there's a UI Reach program at the University of Iowa. And this is a 2-year transition program, and they live in the dorms, and there's classes. It's an awesome program, and we work with them a bit, and it's great program. So where to work? So I'm guessing maybe some of you are aware that a few years back, a lot of what are called sheltered workshops closed down. And that's because of this Workforce Innovation and Opportunity Act that was passed in 2014. And the goal for that was to really encourage integrated competitive employment for folks with disabilities and with ID. And so Hy-Vee is a big employer of folks with disabilities. In this area, Olive Garden, Co-op, Deluxe Bakery, I know you guys aren't from the Iowa City area, but there are some businesses to do that. Unfortunately, there's some individuals that's just not going to work. And many of the folks that I work with, they're not going to be hired by a business when they're at risk of challenging behavior. So I'm hoping we can in the future find a balance here where, yes, we want as many folks to have competitive employment as possible, but there is going to be a continuum. And unfortunately, some folks did lose some jobs that did provide a lot of pride and stability to their life. But hopefully we'll adapt and move on and find other solutions. So where to play? Having something to do is so important, and a lot of times people are just bored, and I think we all kind of know what's happening with COVID. Some of us are just bored. There's really, not much to do. So it's really important for people to be engaged in the community and have things to do. So I have some pictures here of some things that are available throughout the state, but also in Iowa City. Camp Courageous is an awesome camp that I've had many folks go to and they've loved. There's Special Olympics. In town, there's the Studio 13, which is a gay bar in town, but on Monday nights, it's a fun place for, they open it up for folks with disabilities. And there's a lot of Mountain Dew drinking and pizza eating and a lot of dancing going on. Not right now, but pre-COVID. So really important for folks to have something to do, because with boredom comes trouble often. So I can't overestimate the importance of having things to do. So providing support for families and caregivers is so important, and this is a stressful time, stressful transition, and making sure that family is aware of resources that are out there, and providing support to them, because it's tough. It's tough, and they're not. Many parents realize that there isn't a lot out there compared to the kid world. And it can be a pretty scary transition. And so transitioning to an adult provider. So I think it's important to think about this early, because it's hard to find adult providers, honestly, and kind of talk about agreeing on a transition date, like a year, like how old's the kid's going to be, or a certain time to make that transition happen. Important to document in the records their current and past meds that they've been on, document discussions that have been had about guardianship, sex ed, plans for the future. Have a warm handoff. So, sending an email or calling an adult provider to see if they, accept the transfer, developing those relationships between the child and the adult world to help with that transition. It can be really important. Yeah, we started out having a transition program, and even our program here said we were going to see folks for a year and they were going to move them on, and that's really hard because it's hard to find somebody to move them on to, but you just got to keep it on. All right. Okay, so in summary, you know, the transition to adulthood is tough. There's no easy way about it. There's decrease in services, increase in challenging behavior, increased use of psychotropic medications, but there are things we can do to help. So the guardianship, sex ed, live, love, work, play, support for family, and transitioning to an adult provider. So we can move to questions now. I included this picture up here of this documentary of Adam Terrell, who grew up in Iowa, who was adopted by a family, and a family with a big personality. And they created this documentary, and I would highly encourage you watching it. It's entertaining, it's funny, they're all very funny. But it tells the story of transitioning to adulthood and the struggles that go along with it. So, all right.
Thanks so much. That was great. So we do have a couple of questions in the chat box, but I would encourage people to put those in there as we're are answering them. So we have some for Dr. Tate. So one question that we have is, what does CB mean? And this was on the slide when you discussed intellectual disability and mental illness at the beginning. Think a little bit.
Oh, challenging behavior. Sorry.
Perfect. Okay,
This one, intellectual disability, mental illness, and challenging behavior. And challenging behavior we define as aggression to others, so hitting others, hitting themselves, throwing items, eloping.
Okay. And then, is ASD with ID considered a dual diagnosis?
Say that again.
Is ASD with ID considered a dual diagnosis?
Yes. Yes. I think so. Sometimes there's a little, I would say yes. Sometimes the agencies or government agencies where they exactly list autism sometimes is vague, but I consider that a dual diagnosis, yes.
Okay. Can you give us a good resource for handouts for sexuality?
I can send, that's a tough one, but I'll send, how about I send what I've got? Can I send it to you and then you can send it to books? Okay.
For sure. Is it always necessary to get guardianship? We have a health proxy that allows us to help with medical decisions.
Well, I'm not a legal expert, so I don't know that I'm the exact right person to ask. And I have a very, you know, my view is the work that I do and the individuals I see who, you know, utilize the healthcare system a lot, are in and out of the hospital, sometimes have legal difficulties. And so in that case, I really think it's important for someone to have a guardian, just because there's so many decisions and there's, I think, some things the health proxy can't do. If your child or your patient is, I think it just depends on the individual.
Mm-hmm. Let's see. So someone has, one of our family navigators, oops, I'm echoing, hold on one second.
All right.
So one of our family navigators had said that in guardianship, it might be hard for parents to obtain it because of the cost. Parents can't afford the cost of an attorney. Have you ran into that in your own practice?
I have not. That's a good point, though. Yeah. I don't have a good answer to that.
That's okay. Let's see. Can you go over the slide that shows the relationship between ASD and ID again?
Yeah. So autism spectrum disorder is a syndrome that is associated with impaired communication skills, stereotypic behavior, some rigidity in behavior that begins in childhood and is persistent. And individuals with autism can have really high IQ, they can have normal IQ, they can have, excuse me, my pager's going off, they can have low IQ. And so because we have autism does not say anything about what your IQ is going to be. Intellectual disability is folks that have impaired cognitive abilities and impairment in overall functioning in life. There is an overlap between, so you have autism here and you have ID here, and there's a significant overlap between the two. So folks with autism, about 40 to 50% of those people also have ID, and then folks with ID, about 45% of them also have autism. So when I was talking about the dual diagnosis earlier, it's a common comorbidity, but they are two separate entities. And a lot of medical providers, they don't quite understand that. They'll say, well, this person has ID when they have autism, or they'll have autism without ID and they think they have ID, but they're not one and the same. They're two separate things that often overlap.
All right, thank you for that explanation. I'd like to, this is not a question, but just to the group about guardianship. So people have said that legal aid can help with guardianship. Also, Disability Rights Iowa can help with guardianship. And it was one of our first webinars for the Transition to Adulthood series. So I can send out that recording as well in case anyone wants to look at that information. A question that we had too was, could you talk a little bit more about their friendship training? You said that you had offered it before COVID. Could you explain what that kind of looked like?
Yeah, so it was Mark Hines, who's the program director, who's on one of the slides earlier, runs it. So it's a 12-week course in person. So there's a group of about 6 or 7 individuals that come in. So once a week, they have like an hour and a half kind of didactic training about boundaries, money, social media, sexuality. And then once a week, so it's a twice a week class, once a week they'll go out, let's say they'll go out to eat, and they'll talk about, appropriate boundaries and interactions when you're eating, or go to a mall, or they'll practice kind of what they've learned earlier in the week. If you go to that link too, it'll kind of give you more information on that, but there's different modules that they go through each week.
And we'll send out the PDF of the slides with the link too, so people will be able to get that. And a question following that friendship training, is there a cost associated with it?
Yeah. I don't remember what it was, but to be a certified trainer, they have a copyright on their material. So we went, not me, but Mark went through the training to become a trainer, and then is doing the class with individuals here.
Okay, thank you. Let's see what else we've got. To go back to your point about diagnostic overshadowing, Do you see this more in certain populations, like as a health equity issue? And like, how do you challenge this as a clinician in the workplace?
Well, I do think it's a health equity issue, and I see it with people with mental illness, and I think see it with people with mental illness and ID. It just sends me. I get so mad about it. So I'm always advocating for patients to make sure they get really good medical evaluations. And the worst example I have is a patient of mine. His mom brought him to the ER because he fell down and his leg hurt, and they did an evaluation. I thought they just strained his knee or something like that, sent him out. And then mom called me again and said his leg really still hurts. I'm like, well, they get any x-rays? No. I'm like, we got to go back to the ED. Went back to the ED, fractures. They got an x-ray, he'd fractured his femur. And so as a healthcare provider, I'm usually always advocating for patients, calling their primary care provider, making sure they get things done, making sure they get preventable health care done. We've got a good group of providers here that are generally pretty good, but you just got to advocate. We have our Pixie Plummer, our internal medicine neurodevelopmental doc. She does a lot of that, calling around, helping folks access care, because I'm sure you all know that sometimes even to get someone's teeth cleaned, if somebody has challenging behavior, getting them into the hospital to get that done can be hard. So we fight the system a lot, but it is an equity issue and a knowledge issue. Folks with ID have a very high pain tolerance, and so they're not all, but they're not gonna present the same way that I would if I fractured my leg. And so oftentimes people aren't aware of that somebody with ID might not feel pain the same way or present in the same way. So it can't be this, it can't be a fracture, when it could be. Can't be appendicitis because they're not, wiggling around in pain, but it could be.
Thank you for that explanation. Another question we had is that I know that we're in the thick of COVID right now, but what are some different ways that you've seen COVID affect people with ID? I know that you said it may affect like their play, but is there anything else that it might affect their everyday life?
Well, yeah. So one way that we've seen it in the hospital is there's this visitor restriction, and if you need a care provider to help you access health care, that's not a visitor, right? That's a support person. And so we've had to kind of advocate to make sure that that's clear. So I think access to visitors in the hospital was a bit of a challenge early here, and I think it was just a knowledge thing, but I can imagine that probably would be, I think we've got that fixed, a challenge other places as well. So, but that's in healthcare. But outside of healthcare, many of the agencies that I work with are really locked down, and folks with ID oftentimes or autism have a hard time wearing a mask, and so that will limit their ability to go places. Staff, many agencies are short-staffed, so even if they could go wear it somewhere, they don't have enough staff to go any place. So I think it's restricted people's lives more so probably than someone like me. Well, absolutely, where like me, and probably access to healthcare as well.
All right. And we have one last question from our audience. So you had mentioned that it might be difficult to transition patients from the pediatric world to the adult world. How do you deal with these issues in more rural patients? So a lot of our clinics are throughout Iowa and more rural places, and where there might not be trained providers for them to or transition to. So how do you deal with that situation, especially when it comes with transportation issues or other kind of issues like that?
Yeah, that's a great question. I don't know. I don't have a good answer. I mean, we have telemedicine. That's maybe a good thing that's come with COVID to make care more accessible. You know, I think educating, this isn't an answer for right now, but we're trying to educate providers now, or learners, at least medical students and PA students, so that when they do go out in the world, they'll have more of a knowledge base. But it's hard. I mean, I don't have a good answer. You know, we're happy to provide education and training to anybody that's interested. Happy to do consults, but there isn't a good answer other than, you know, the best answer I have right now is telemedicine, and it's not available to everybody, and it doesn't have all the specialties either. I wish I had a better answer.
It's actually the age-old question, right?
Yeah.
Well, it doesn't look like there's any more questions in the chat box, but thank you for taking the time to do this. We really appreciate it. And for everyone on the call, I am going to be sending out a follow-up email with the credit information. If you are looking to get FPSS credits, please email me so I can get that certificate made for you. And a recording of the presentation will be sent out as well. So thank you all, and have a great rest of your day.
Thank you.